and welcome to the Alabama Public Health Training Network. The current Ebola epidemic is the largest in history, and the CDC is taking precautions to prevent additional Ebola cases in the United States by assessing travelers coming from countries with Ebola cases. The ADPH Bureau of Communicable Diseases is responsible for monitoring travelers arriving in Alabama and conducting contact tracing if the traveler becomes symptomatic. Today, we will detail the process for the Alabama Department of Public Health field staff to complete Ebola monitoring and contact tracing. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year and will expire on March 31st, 2016. I'm Dr. Karen Landers, Assistant State Health Officer and Medical Consultant for TB Control and Immunization. Other ADPH staff included today is Dr. Albert White, Infectious Disease Physician, Dr. Mary McIntyre, Assistant State Health Officer for Disease Control and Prevention and State Epidemiologist, Kelly Stevens, Epidemiology Director, Shirley Offit, Epidemiology Surveillance and QI Manager, and Cindy Lessinger, Immunization Director. Anthony Merriweather, Director of our STD program, and Pam Barrett, TB Director. Welcome, everyone, and now we will begin the program with Dr. White.
Okay. Good morning to all, and we're glad to be here today to participate in this program. Are we going to do the objectives first?
I can briefly review the objectives if you would like for me to do so. Today we will talk about basic Ebola virus disease information. We will explain the assignment of risk categories, and we will delineate the role of the Bureau of Communicable Disease in the EVD monitoring process. We will also identify criteria for active and direct monitoring, as well as verbalizing documentation required, and we will verbalize required documentation from the travelers going from state to state. We will also discuss the similarities between directly observed therapy and direct active monitoring, as well as the role of the BCD staff in EVD monitoring. And now we will turn this over to Dr. White.
Thank you very much, Dr. Landers. It's a pleasure to be here again today participating in this program. As we know, Ebola is still out there. It has not resolved. It still is a rare disease, and it causes a real deadly virus illness. About a year ago, it was in March of 2014 when Ebola burst onto the scene, with the first cases being identified in Guinea in West Africa. And since then, that outbreak has been ongoing. The virus, the Ebola virus, was first identified in Zaire back in 1976 near the Ebola River. And since then, there have been multiple outbreaks in the region in Africa and now in West Africa. As of March 8, 2015, there were over 24,000 cases of suspected, probable, or confirmed Ebola virus disease in the 3 countries mainly involved in West Africa. And to date, there have been over 10,000 deaths that have been reported, again, from the 3 West African countries. And those countries are Guinea, Liberia, and Sierra Leone. This is a map of the region in West Africa where the outbreak started and where it is still ongoing. Guinea is to the north, Sierra Leone is to the south, and Liberia is more towards the southwest of those 3 countries. The Atlantic Ocean is a main border of Liberia, Sierra Leone, and Guinea out there. As you can see on this graph, the green areas which appear to be rectangular or circular forms are area where there's still ongoing cases. It is a good thing to know that for the last 3 weeks there have been no new cases reported in Liberia, but there is still ongoing cases in Guinea and Sierra Leone. And it's not until we have no cases for 2 incubation periods, 42 days in either one of these countries, before we can say that Ebola has been brought under control. And it's sad to say that that day is still far away, and we hope that sometime soon we will be able to say that. The problem is that people are still traveling to those areas, and people are still coming from those areas and going to other countries. And this is why we're here today to talk about what we do with these travelers when they come back here to the United States. The Ebola virus is thought to originate or be maintained in animals in the wild, especially bats. And sometimes these bats, they transmit them to other animals like chimpanzees and other mammals in the region. They come into contact with humans when humans come into contact with these animals, either through accidental contact or through hunting and means of harvesting these animals for food. And when it gets into humans, then we have this circle that humans can transmit to others, and it can be very, very devastating when it gets into a community. Unfortunately, these incidences occur in poor countries, in remote areas, and it can spread if good hygiene is not practiced, and burial practices and all these things. And that's where it has been raging havoc in West Africa over the last year. This is a map of a portion of Africa that highlights the different countries that we have seen Ebola over the years. There have been over 20 outbreaks that have been described over the years, and this outbreak in 2014 has been the largest outbreak of Ebola ever documented, and it is still ongoing. There are 5 known subspecies of that virus, and the species that is causing the majority of the outbreak now is called the Zaire Ebola virus species in West Africa. The United States have had its share of Ebola. We all are aware about the original case, Eric Duncan, that came from Liberia way back in August, September, went to Texas, and he was hospitalized there, and subsequently 2 other healthcare workers became infected who have survived the illness, and they're out about doing their business now. But there have been 10 patients overall who have been treated in the United States. 8 of them have survived, and 2 of them succumbed to their illness. Right now, we have a lot of people who have traveled to the area, who are people of interest who are being worked up, but we do not have an active case. I know within the last week or so, a patient was transferred from the Sierra Leone who is at the NIH and is receiving treatment there, and we are praying that things will go well with that particular patient. 2 of the patients who acquired Ebola in West Africa and were transported to the United States for treatment again succumbed to the illness. The rest of them survived. Why? Because we have excellent medical care here in the United States, and we're able to provide the kinds of services and treatment that those patients need. How is Ebola spread? Well, I'd like to first point out how it is not spread. It is not spread by casual contact. It is not spread in the air. I know there has been a lot of questions about this over the past year since we've been looking at Ebola, that people think that it's airborne and all of that, but we know that it is not airborne. And one of the recent documentation about this is that the patients that traveled and went to, say, to Nigeria, or the patient that came to, Liberia, none of them were really, very sick or so, and no one on any of those airline flights where people who were supposed to have been infected, who were not symptomatic, got any Ebola from being on that plane with them. The ladies in Texas who went to Atlanta, to Ohio, again, all of those people have been monitored for several weeks, months now, and no one has been shown to have gotten Ebola like that. We know it's not spread through water. We know it's not spread through food that is grown or legally purchased in the United States. And it's not is not spread through beef or cattle or anything that comes, from those areas. That had been another concern that people have asked, well, is it in the food or things that come from those areas? We know it is not spread through those mechanisms. The way Ebola is spread is through direct contact with body fluids of someone who is sick or someone who has died of Ebola. And those body fluids that we're concerned with includes blood, vomitus, urine, feces, semen, saliva, and any other body fluid that may have any blood in it or so that has the potential to infect someone. Again, that person has to be sick, and you have to be in contact with their bodily fluids before it can be transmitted to you. Not just being in the same room or passing down the hall that the patient passed down. You're not going to get Ebola like that. Contaminated objects like needles and medical equipment are other methods in which the virus can be transmitted, again, assuming that those instruments, those who have come in contact with the patient's body fluid, blood or something, and if you're not wearing protective gear and they come into contact with you on your bare skin, on your mucous membranes, it can be transmitted to you. What are some of the early signs and symptoms of Ebola? There was an extensive study reported in the New England Journal in September of 2014, where the first 9 months of the outbreak in West Africa was analyzed, and all the patients were they had the details about what they presented with. And the things that stood out among those patients who had Ebola, who had confirmed Ebola, were that they were febrile with a temperature of over 100.4 degrees Fahrenheit. 87% of them had fever. 76% of them were fatigued. They were weak. 68% showed vomiting. 66% showed diarrhea. And about 65% were anorexic. Another percentage of them, 50%, a little over, had severe headaches. Some had abdominal pain, myalgia, and difficulty in swallowing. Some had cough, difficulty breathing, sore throat. These were lesser symptoms in the 20-30% range. Some had conjunctivitis and unexplained bleeding. And every time we've seen pictures of patients with Ebola, on the internet or other places, you see them with blood coming out of their mouths, or, out from the eyes or something like that. And that seemed to have a real, sort of profound effect on people. But in this study, they did not see a lot of people who had this bleeding. And sometimes when patients do have bleeding or coagulopathy, that means they rarely are seriously ill. Where in the body have the Ebola virus been detected? There are several body fluids here listed on the left here. You see in the blood, you see saliva, you see urine, you see tears, semen, sweat, vaginal fluid, rectal material, feces, and even milk. But again, the virus is concentrated mainly, especially early on in the acute phase of the disease. You will see it mainly in the blood, in the saliva, in the sweat and skin glands, and in the rectal fluids. And later on, as the course of the illness goes on, you can find it in other places, which can persist in the body. But we have to be careful about those liquidate fluids that come from the patient early on in the disease. These are the ones that are highly infectious, and they have a high viral count. Other important information about Ebola is, again, Ebola can only be spread to others when they become symptomatic. And this is something that we have seen. It has borne out. A lot of the people who have been to the area and come back and have been monitored, if they did not develop any of those symptoms that we talked about earlier, that I mentioned earlier, it is unlikely that they have Ebola. It's only when symptoms develop before they begin to show Ebola. And there are times where sometimes people will begin to have a little bit of symptoms, and we test them, and their test will still be negative, and because it takes a little bit of a while before the virus can be isolated. Symptoms can appear between 2 and 21 days after exposure to the illness. So just imagine if you were exposed, if you've been in the area, you had a family member, someone who was sick, and you left the area and came back here. If you got sick in 2 days, that means you rarely had a big exposure to it. The inoculum dose also influence how early someone can become ill. And if you get ill out to that 18, 21 days, you probably may have a milder case of disease, but again, you are still infectious if you become symptomatic. the viral load increases as the patient becomes more ill. And when the patient becomes ill, they become weak, they're lying down, they can't do anything for themselves. That's when they're having diarrhea, they're having vomiting. Those patients are rarely contagious and infectious. This is a slide that shows, again, a graph about the critical time period in which you can find either antigens or antibodies against the virus. The top line is showing the graph that shows viremia, and then you see later on, after the 10th, 11th, 12th, second week before IgM and IgG begin to develop. You can see the red line that shows fever. That can occur early in the illness. Within the first couple of days or so of infection, you will get a fever. And then you see the RT-PCR. PCR, that's checking for an antigen of this virus. You can see that in the first couple of days, you see those 3 dots there. It shows that if you are tested early, you may not show the virus in your system. And that's why sometimes when people have a high suspicion they've been in the area, we try to, if that first test is negative, we try to test them again in another couple of days so that we do not miss the diagnosis. ELISA for IgM and IgG, those are antibodies that occur, and it's usually after the individual has been exposed and has some time to develop antibodies. So that's not a good test to try to find out if someone has Ebola, because you could miss it early on. The RT-PCR is the way to go, and because it's the best test that can detect this virus very early. It's used to diagnose acute infection. It is more sensitive than the antigen detecting ELISA, and it identifies virus-specific genetic material, and is performed in specific labs that are certified to do this kind of a testing. I know there are lots of research going on out there now to try to improve the means by which the virus can be detected, and to be able to use it in the field, so that the people in the region in West Africa, when they're called to a village or go somewhere, they don't have to truck this blood back to a capital city, back to a mean area before they can get the testing done. That wastes time. That means patients have to be isolated. Sometimes they are put in holding areas where there are cases of Ebola, people in that area, and you have someone who you're testing and putting them in an area where they could become contaminated and infected with someone there. So the earlier the testing can be done and the diagnosis confirmed, the better it is for the individuals who are being looked after. Again, the sample collection, we have to collect blood. It's usually 4 millimeters of whole blood, and there are plastic tubes used. There are no glass tubes or heparinized tubes used. And the lab people who are getting the blood, they have been instructed about this and using the appropriate sampling device to collect the sample. Case definition for Ebola, and we struggled with this early on in the disease, and I think we had to make some modifications, because for someone to be of interest to have Ebola, they have to have been in the region of concern. And first, we used to have this where we say, oh, if someone has fever and they're coughing, they're vomiting or something, and then we'd find out if they've been to the region. That had a whole bunch of people who had symptoms. Those symptoms that we mentioned could be any other disease. All the viral processes can cause fever, can cause diarrhea, can cause abdominal pain, can cause fatigue. So not everybody who has those things mean that they have Ebola. You have to have the epidemiologic risk factor that you have traveled to the area. And I think this is important because our experience over the last year or so, we found that it was delaying the care of people who say, I remember a lady who was vomiting, and she said she was vomiting blood, and she had abdominal pain and all that. And the EMS folks were scared to go get her because somebody said that, she knew somebody who had been to Africa. Well, she hadn't been to Africa. She knew the person 2 years ago. So all of those things don't count. You have to have the epidemic factor. You've been to the area within the last 21 days, got sick, and then if you have these symptoms, then you be of concern. So I think we need to have that in the back of our minds. Our DISs, our folks who are going to be helping us going to monitor these people, again, because of the way we do it now, there's a better chance that we'll be having to go to see the right people and not just anybody who may have pancreatitis and coughing and vomiting blood that we will be concerned about. So I like for us to remember that fact. Elevated body temperature, subjective fever, and symptoms, the headache, these are the symptoms that you have now that would suggest that you could have a disease if you have come from the area, if you have been exposed to the area, if you have a family member who has come back and been sick and all that, then will be considering you, but not just anybody who has these symptoms without the epidemiologic exposure. Ebola, again, only spreads when someone becomes ill. They're symptomatic, they're having body fluids and all those kinds of things. If the patient has not become ill, has not had symptoms 21 days after the exposure, there's not a possibility that that patient can become sick with Ebola again. And those are the times then we release the patient from monitoring, and then they can go on and do all of the different things. In this, the rest, other parts of this program will go more into this about, who the patients are, who will be monitoring, to what extent we're going to be monitoring these patients, depending on what their risk factor is, how much the possible exposure that they may have had. The outbreak again of Ebola started in West Africa just over a year ago. These are the 3 countries that are currently still in the limelight about Ebola: Liberia, Sierra Leone, and Guinea. Liberia has had now 3 weeks of no new cases, but the borders with Sierra Leone and Guinea are so porous, and Liberia has opened their borders with those countries, so I don't think they're out of the woods yet. There were a couple of cases that came from Nigeria, that has been resolved. A couple of cases from Senegal, that's resolved. A couple of cases from Mali, that's resolved. It's only now, these are the countries where it is, and people are still traveling, people are still going to those areas and coming back over here. So we still have to be vigilant about how we follow these people to make sure that they do not become infected and they do not infect others here. I will now turn the podium over to Dr. McIntyre, who will begin to discuss our policy about Ebola and what we expect our disease control staff to do. Thank you.
Okay, good morning. What I want to do is actually explain why we're here. Why are all of you happen to actually listen to this webinar? One of the things that is part of our mission, or the most important part, is to protect the public's health. Exactly. And being in disease control and prevention, we're trying to make sure that we actually prevent and control any communicable diseases and infectious diseases. That includes Ebola. So one of the things we are tasked with doing is making sure that you get the information that you need to not only protect the public's health, but to also protect yourself. So I'm going to go through some top 10 Ebola response planning tips that came from the CDC. And specifically, these were put out and they're still available on the website at CDC. I also want to mention that we do have an Ebola, ADPH Ebola web page. We have, for those people who will be part of the response, there's actually an Ebola response page with documents and tools that we use. So I invite anyone who hasn't visited the Ebola webpage to do so. The response page requires that you go in through your LCMS using your password, because it is not available to the general public. But it is available to staff that have the LCMS passwords. So let's look at the specific tips. There are 10 of them. When we look at healthcare system preparedness, one of the things that we had to start doing early on, and we had started even before that first index case that occurred in September. I think he was September the 23rd or 24th. We had actually started a couple of months before then. Well, when that happened in Texas, it pretty much pushed the timeline for everyone, which meant that as an agency, we really had to then rev up to try to get things in place. We were moving, but we were moving and being what we thought was pretty aggressive, but it didn't end up being aggressive enough. So part of the things that is required in order for us in this planning process is looking specifically at public health readiness and risk communication, how we got the information out to staff and also to the public about exactly what Ebola is and how what the risk factors are that Dr. White just talked about, and if you're at risk or not, and how do we protect ourselves, those type of things. We've done a lot of information as far as from a risk communication standpoint, not just with employees, but with what we call partners, like the Hospital Association, webinars, webcasts. We've done grand rounds at hospitals, trying to get the information out to the staff at those facilities. And when I say we, it's been a group effort with people going out in different areas, talking to the various entities, okay, to make sure that information is out. We've also done public TV, invitations to speak about for the public to understand and put in terms that they understand what those risk factors are. Information sharing, it's not enough for us to have it at ADPH. We have to provide it to our partners. We have to work with others. EMS is just an example of a group. The Hospital Association, making sure that information is shared. Making sure, for number 4, with travel-related information, we send information to like the universities. We've spoken to the school system, Department of Education. We provided them with resources, fact sheets for parents to understand what the risks are, and if they are traveling, what they need to avoid. And that's been a lot of the information that we put out. Where to go, and if there's an issue or problem that occurs while they're traveling, what they need to do. So tip number 5 deals with public health laboratory guidance, specifically the information on handling specimens, collection, transportation, what type of specimens, what testing will be done, and how to submit it. Our state lab, BCL, actually has the ability, after going through proficiency testing with the CDC, to actually do Ebola testing. Now, the testing performed by the state lab will be considered to be a presumptive positive, a preliminary test on the Ebola specimen. But we can get results quickly, within 8 hours of when that specimen arrives, which is extremely important. If we end up getting a presumptive positive, we can then make sure that the people at the hospital and everyone else has that information. We can start that contact tracing process quickly to make sure that we have everything in order and that we are identifying people that we're going to need to follow. We have a process to get the blood transported to CDC so that it can then be tested. They can turn it around within 24 to 48 hours. If the test is negative at the state lab, that is the final say-so on that test. But a lot of whether or not it will be repeated will be dependent on when the person's symptoms started. So if we identify that those symptoms were less than 72 hours, we will advise that they retest that person and that they remain in isolation. Lab safety protocols, procedures, PPE, deals about not just with public health, but other laboratories that may be involved in the process, especially with facilities that we're trying to get to be able to assess and evaluate. Right now, every hospital is considered a frontline facility, which means that they all have to have the capability of, if someone shows up at that door, to be able to isolate them and to assess and evaluate, which means that they have to be able to ask the initial questions. They can't say, you can't come in here, but they need to know what it is they need to do. And EMTALA requires that if a person shows up at the door, that they can at least do those 3 things, which is isolate, evaluate, and assess. Number 7 deals with public health surveillance definitions. And this deals specifically with the case definition. We call a person under investigation, or a PUI, someone who meets the epidemiological risk factors, which means, first of all, that they traveled to one of those 3 countries that are now considered to have widespread infection. Okay, so just the 3 countries that we've already heard: Guinea, Liberia, and Sierra Leone. Now, the other category could potentially be someone who has had an exposure as a U.S. healthcare worker to a patient with known Ebola. Well, we know that right now there's only 1 person in the United States with known Ebola. We know where they are, okay? So it would not be in Alabama where we would be worried about that at this point in time. One of the other things that we also know is that because we're looking at the person's under investigation, and also we're not a person's under investigation, but we're monitoring, which you're going to get more details about, We know that how many people we have within the state that even potentially fall into a risk category that I'm going to give you a little bit more information about in a minute. Okay? So when we look at specifically the epidemiological tools and what we're doing as far as implementation, there are lots of them. We've got line lists. We've got tools to actually be able to get the temperatures recorded, to follow up that surveillance staff use, to input the information about what the fever and the symptoms are on these persons. We have information for EMS that we work with as far as responder safety, what they need to do. We've got a process in place that if they actually pick up someone, we can identify whether that person is actually on our list, which means that they're being monitored, and whether there's even anything to worry about. We still get what I call false calls, which are we get people contacting us about someone who sat next to someone in they were in Italy, and the person they sat next to at the table had been in coming from Sierra Leone. We just talked about you can't get it in casual contact. You can't get Ebola from someone, first of all, that's not symptomatic or where you don't have direct contact with, which is some of the things that we're going to explain today about how to protect ourselves. Clinician and responder CDC guidance on worker safety is extremely important. So the information that you're going to be provided today will protect not just you, but your families and the community at large. Okay? So when we look at the policy overview and when active arrival started, it actually occurred after our index case, okay, because there was an outcry with people wanting more to be done, okay. So the affected travelers arriving from, it affects travelers coming in from those 3 countries and Mali, okay, involves 5 airports. Now this says approximately 70% of the travelers. That was before they routed everybody. Now it covers 100% of them. Initially, when it was implemented, it covered the majority of travelers. Now, every single person that's coming in from the affected countries have to be routed through those airports on entry to the United States, which means that the entry point screening will actually catch a lot of what's being done. Okay, so when we look at the 3 airports, we look at New York, Washington, Newark, Chicago, O'Hare, and Atlanta. So the one that affects us the most is the airport in Atlanta, but we've gotten people from all of them that are coming to Alabama as their designation, which means that based on that, we receive information from that screening process and entry process, and it comes in through our EPIX. We also sometimes get a call notification, so we get it sometimes several times, which is really good for us. So monitoring is coordinated with the state where the traveler actually will arrive as their final destination. Now, we also sometimes get people that are moving from one state to another state, and we do a handoff, which means we get notification that once someone may have gone to a specific state, maybe Mississippi, and they're staying there for a certain amount of time, but ultimately they're going to end up traveling to Alabama, and we receive that information, and there's a handoff that occurs from one state to the other state. So let's look specifically at preventing Ebola by screening travelers. Okay, there are actually a number of components to what happens. There is an exit and entry screening process. What the exit process is in the country where they're leaving, Guinea, Sierra Leone, or Liberia, before they can actually get on a plane, okay, they go through a screening process before they're allowed to actually get on the plane. That's called exit screening. And they have to go through identifying the risk factors, answering a questionnaire. Have you been in contact with anyone? Have you attended a funeral where you handled the body? All of those questions. They also get a temperature check to make sure that they're not febrile. Okay? And then they get on a plane and they come to the United States. Now, sometimes they don't directly travel to the U.S. Sometimes they go through other places for a couple of days. So we actually look at the date when they left West Africa as that initial time frame of when that 21-day monitoring process and stuff that we have to do would end. So when we look at the next step, this is the exit screening I've identified. If they identify any problems as far as with exposure, symptoms, any of those things, guess what? They're not allowed to get on the plane. Okay? They're told it's not okay for them to travel. So what we're ending up with as far as the ones that are given an okay are some of the low risk ones that have been identified on the exit screening. Now, some people do not always tell the truth. We know that that is one of the things that potentially happened with the index case because he had known exposure. And there was still exit screening in process at that point. Now, we did not have entry screening, but there was exit screening in process. So based on his exposure risk, he would not have been allowed to travel. So that's one of the things we also have to remember, which is why we now have entry screening. When they enter the United States, what happens is when they come in through those 5 airports that they've now been sent to, there's a process where there's an initial screening done. If they are found to have a high-risk exposure, even if they're not symptomatic, they are not okay to travel any further. Not at that point. They get stuck within the location of where that initial screening occurs, okay? Some risk or low risk, which is what we've been receiving, are allowed to travel on, but they're given a packet, and I don't know if we brought one. We probably did. You have one? Okay. They're given a packet that includes a thermometer where they can actually, and they're given specific instructions on what they need to do. They're given their phone number for the contact for the state that they can call to make sure they get in contact with us so that they will be monitored. All of that stuff is part of that kit that they receive. This goes into the levels as far as risk categories, and I'm actually going to get into a little bit more detail with that. Remember on the diagram we just saw that high risk, they get stopped. Some risk, low risk, no risk are the ones that travel on. So that we end up doing and actually doing monitoring. The some risk are the ones that can also be broken down into the active monitoring versus direct active monitoring, and it depends on specifically whether they're healthcare workers and some other things as far as how they get categorized in the some risk. So when we look at the actual guidance provided for movement and exposures, there is information, and there are actually a couple of tables. There's a simple one that you just saw. There's also this one that gives a little bit more detail, which talks about what has to happen with a person at high risk. They have to be in direct active monitoring. They're not allowed to travel on. And because we do not have an airport, yay, we're not one of the 5, it means that the persons get stopped at one of those other places, which is great for us, okay? So this is when it's a great time that we don't have one of those international airports for people to enter into. Some risks can be, they're in the direct active monitoring categories, and the low risk active monitoring versus direct active monitoring. Now, there is a big category, a big chart that we did not put up here that shows a lot of detail. Okay, this information is available on our website and on the CDC website. And what it does is it goes into the specifics of who falls into where when it comes down into those categories. And what it does, and I'm just going to give you an example under some risk. What it does is that when we look at the some risk categories, it will go in and it talks about whether or not a person about direct contact but wearing appropriate PPE. And it goes into the fact that they're asymptomatic, but because they provided patient care or they were involved in that situation, we have to do direct active monitoring on them. Now, under the low risk category where it talks about active monitoring or direct actor monitoring, it really depends on looking specifically at, we look at the fact that they were wearing appropriate PPE, but there may be information that identifies that there may have been some type of a break or an issue. Under here follows U.S.-based healthcare workers caring for symptomatic Ebola patients while wearing appropriate PPE, okay? And that is where we have that direct active monitoring. Also, travelers on an aircraft who were sitting within 3 feet of a person with Ebola, within 3 feet of a person with Ebola. We haven't had any of those that we've received in Alabama, but there have been a few. None of those have ended up contracting Ebola, which tells me that that's really, really a low risk of any issues. So when we move on to looking at policy overview post-arrival, adding safeguard to protection for the public's health, notifying state and local authorities of the patient arrival, all of these things are what I've just described, and it allows us to establish daily contact with those patients. For those persons under active monitoring, it's a call. For a person under direct active monitoring, which is why we're here today, trying to make sure we've got everyone ready to be able to assist, because it's not any different than what we do with directly observed therapy in some other areas, and to be ready to do contact tracing, which is very important, and which we already do as part of communicable disease in several areas, okay? So when we look at the monitoring process, it's 21 days. It allows state and local public health to gather health information and to screen for EVD. It also allows us, if in the event EMS contacts and calls, for us to be able to say, yes, we have a person in Jefferson County that's undergoing direct active monitoring, okay? And then they will ask, based on that process, well, this is the person we have, and we can say this is not it. This is not the person we are monitoring. The person you have is not at risk. So when we look at the national monitoring numbers, okay, they average at least 1,000. We get a weekly report now. We did not always receive this. It actually includes all of the states. Alabama has to report, and as part of that reporting, we see each of the states listed and how many people they monitored in the week that's reported. We also know the total numbers. We know that right now, because it does average about somewhere between 1,000 plus to the high has been 2,000 during that week around Christmas. Okay, and actually the week of December the 22nd through the 28th, 2,106 people actually entered the United States from those countries and and they went through the entry screening process. As of March the 9th, 2015, and this is the weekly report called Week 17, there were 1,484 persons in active monitoring within the country, and persons in some risk or high risk category were only 116. So you can see that the numbers are not really that high for that category that falls into some risk or the high risk. Low risk, no risk would be the majority. This actually gives you the process that happened based on those 2 healthcare workers in the index case, the number of people involved, and what I always mention to people is to remember that that index case, Mr. Duncan, we all know it, that he was in an apartment with children, other people that were there when he was really, really sick, but when he presented to the emergency room. And we know that he went once, and then he was sent home, and then he went again, okay, and he was admitted. That out of that, despite the exposures, that only 2 people became infected with EVD. And those 2 people were the 2 nurses that provided direct patient care. And we know at that point that we really were not where we needed to be as far as hospitals and as a country when it comes down to making sure that people are trained. Okay? direct contact, and none of the people in the apartment with him became ill or infected. This is Alabama as of March 16th. We've actually had a cumulative total of monitoring events of 44. We've had at least one person that has come through and been monitored for 3 times. And what you all have to remember is there are some people who work in other countries. There are diplomats. There are folks that travel back and forth. Okay? So this person has not had any symptoms or any issues, even with the frequent travel back and forth. We've got 2 being actively monitored now. So I'm getting ready to turn this back over now to Karen, and she's going to finish up with our policy overview.
Thank you, Dr. White and Dr. McIntyre, for a very informative discussion and very educational. I think this will allow us to understand how we in the communicable disease programs can work together to assist the field surveillance staff. And that's really the reason that we're doing this education. So I want to close by speaking to the issue of direct active monitoring participation by the disease control staff. What we have to understand is that this is a process that is well controlled. This is a process that we receive regular information, and we have to understand that when we are doing this, we are all together. We're all a team, and we all have experience in disease control monitoring and management. So I think the first point is very important, that we'll be assigned a direct active monitoring patient in coordination with epidemiology. It will not be something that just pops up on our screen. This will be very well coordinated. And also the workload and schedules will be considered in this assignment should we have a direct active monitoring patient. For example, we know that right now in tuberculosis control that we're working some outbreak situations. We know that we've just recently had the concern about measles in immunization. We know that STD on a regular basis has outbreaks occurring that they're working on. So while immunization is going to lead out in this, there will be situations where there will be support and TB may take the lead, or STD may take the lead. So we're all in this together, and I think that is an extremely important point for us to make. In addition, I want to just reemphasize, and that's why Dr. White is here, Dr. McIntyre is here, and I'm here as the physicians that have been integrally involved in this at the state level, as well as the support that we have received from Dr. Kahn through Jefferson County and the support that he has provided us at the state level. You'll be supported in your program. We will support each other. We will all work together. And in addition, just to finally say that should something arise, should there be a question to arise, disease control staff will have direct and immediate access to expert guidance. And that includes, of course, Dr. White participating with us, Dr. McIntyre participating, Dr. Kahn participating, and my participating. Should something arise, should an issue or a problem arise, certainly we're going to be there with you. It's not going to be something that you're going to be out there alone. And kind of along those lines, I wanted to just mention a couple of practical points, although after the break, Kelly, Shirley, and Cindy, as well as Pam and Anthony, will talk a little more about the process. And also we're very pleased to have in the audience a DIS from Jefferson County who I hope will make a guest appearance here and talk a little bit about his actual hands-on, if you will, his hands-on with gloves, experience taking care of a direct active monitoring situation, and he's here to share his story, and I hope he will do that in the second half. Certainly, should you have a direct active monitoring patient assigned to you, you're going to call the patient first. We all know what it's like to try to track patients down in disease control. We're going to call the patients. People under direct active monitoring are supposed to remain available. Okay? It's not just, well, I'm out doing this or I'm out doing that, I'll get back with you. When they're under direct active monitoring, they're supposed to be available. They're supposed to be where we can get in touch with them. So we'll call the patient, first of all, that we're going to be doing the direct active monitoring. And if the patient reports no symptoms that day of EBD from the phone call, then we will proceed with the daily, once-a-day, face-to-face visit. However, if the patient reports symptoms of EBD, then we're not going to make that visit. That will be a situation where we will immediately contact EPI and institute a referral for the patient to the assessment center. So basically, if they report symptoms, you're not going any further. You're calling, and you're calling for the next member of the team to take the ball. And just some other practical instructions, and again, I'm very pleased that we have an actual person who has done the direct active monitoring with us. You know, one of the most important points that all the literature has made is that we're supposed to make this visit standing at least 3 feet or greater from the patient. Now, are we going to bring a yardstick and measure? Well, you know, probably not. Many of we women who in our past lives had to learn how to sew will know that direct active monitoring and having a 3 feet distance is, you know, approximately an arm's length, depending on how long your arms are. In addition, we will have the person doing the direct active monitoring to wear gloves. They'll have those gloves provided. Those will be available. And this will be in case the person doing direct active monitoring needs to touch the thermometer that the person holds up for them to read. So we'll have those gloves, and we'll have the, after the gloves are used, and they can be removed and placed into a zip closure type bag, and the examiner will perform hand hygiene. And again, this will be in order to add an extra layer of protection, but remembering, as Dr. White said, and I defer to Dr. White as an infectious disease specialist, this is what he does all the time. Person's not symptomatic, they shouldn't be transmitting Ebola because they're not symptomatic. That has been in all the literature that we have read on this subject, and this has been studied fairly extensively. So I think we need to understand, again, in closing here, and before we go to questions, is that we have information regarding how Ebola is transmitted. We have information regarding how it is not transmitted. And Dr. White has given us that discussion. Dr. McIntyre has given us the overview that in spite of thousands of people being monitoring and the numbers we've had here in Alabama, we have not had a person that has been symptomatic, and we have not had a person that has transmitted Ebola. There were the unfortunate cases of the healthcare worker in Texas, but we have learned from that experience. And I think that gives us the confidence to go forward with the information that we know, using our experience in other disease control programs, and work together to continue to protect the health of the citizens of Alabama. I want to stop here and entertain any questions that we might have at this time.
I don't see any email questions at this time. Do we have any callers? No callers at this time.
Okay, do we have any questions from the audience? Okay, if we have no questions, then we will take a 10-minute break, and then we will resume our program on Ebola monitoring and contact tracing training. Thank you. Welcome back to our discussion on Ebola monitoring and contact tracing training. We're very pleased in our second hour of this discussion to lead off with Kelly Stevens, who is the Director of the Division of Epidemiology. Kelly will give us a discussion of active monitoring, and then we will go to our other speakers, Shirley Offutt, Cindy Lessinger, Anthony Merriweather, Pam Barrett, and our special guest, DeVellis Dumas. Kelly?
Thank you. Before I talk about the active monitoring, I would like to give you a little bit of background of how we developed our policy in the first place. So each traveler coming into to the United States from these Ebola countries are given a care kit when they land and when they're evaluated. The care kit has several pieces in its envelope. It comes in an envelope, and it has an introductory card that tells the traveler what is in this care kit. It has instructions on performing the daily health checks and the reason for the daily health checks. Instructions on using a thermometer, and the thermometer is also contained in the healthcare kit. Some symptom pictorials, and these travelers often speak French, so these kits come in French and in English. And another very important form for the traveler is the daily monitoring form, where the traveler will record for 21 days any symptoms and signs and their temperature twice a day. They are given a small wallet-sized card that includes some instructions of whether or not, if they become symptomatic and have a temperature, who to call and that they should immediately call. The CDC provides this general number, but in the health care kit there is a number to the Alabama Department of Public Health and each state public health as well. So for our protocol, our staff can go to our internal Ebola webpage, which is at adph.org/Ebola response. And it'll require your LCMS user ID and password to log into that site and get to the protocol. It's under the ADPH documents and then monitoring. I encourage everybody to read that protocol and contact epidemiology if you do have any questions about it. Again, the protocol was prepared using CDC guidance, and a lot of this information has already been reviewed with you by Dr. McIntyre, and I'm not going to go into great detail, but I am going to briefly go over some of the more important parts that leads us to our protocol. Again, at the airport, the risk is assigned as high, some, low, or no identifiable risk. If someone is assigned high risk, they are not allowed to travel to our state or any other state until they are evaluated further. And these risk exposures for high risk may include needle sticks from treating a patient with Ebola, or using direct care without using proper PPE, and living in the immediate household of an Ebola patient. Again, we won't receive these travelers in our state until they are evaluated further and their risk closely monitored and assigned. Some risk exposures, we may get some of these folks into our state. It includes direct contact with an Ebola virus disease person while he was symptomatic, but while they were wearing protection. It also includes close contact for prolonged periods. And this is a very important word. Prolonged period is defined as more than an hour. And again, for some risk exposures, it would be while they were not wearing personal protective equipment. Most of our travelers are low risk, but not zero. And these folks probably had close contact with an Ebola patient for a very brief period of time. But the key factor is that these travelers have been in a country with widespread transmission of Ebola. The contact, again, is considered brief to be assessed as a low-risk exposure. And brief direct contact, shaking hands, again, remember the prolonged is for more than an hour and brief is shaking hands. Brief proximity is also very important. Being in the same room for a brief period of time, again, less than an hour, with a person with Ebola while the person was even symptomatic. Traveling on an aircraft with a symptomatic person. No identifiable risk exposure is when they might have had contact with an asymptomatic EVD person who had contact with an EVD person, or having been in a country that had widespread transmission or cases and they don't have developed good control measures in that country. The no identifiable risk exposure is very important for our staff who will be conducting direct monitor to understand and probably relieve their stress that they are going to be considered no identifiable risk, because when they do their direct monitoring, it will be, they will check, make sure that person is not symptomatic before they go. They will be not in close proximity, maintaining that 3-foot distance for a very brief period of time, enough time to read the thermometer. So our staff conducting direct monitoring will not have to be monitored themselves, and it should relieve our stress a little bit about our exposure. Again, there's some very detailed explanations about what it means to be no identifiable risk. Now, with monitoring by ADPH, again, if we ever got somebody in Alabama that was identified as high risk, this person would have had to go through further evaluation after being assessed and given the category of high risk before ever landing in Alabama. But monitoring would include direct active monitoring, and it would be performed by our immunization staff, our local immunization staff, if available. Again, schedules will be determined. And any contact tracing associated with that monitoring would be conducted by the STD local staff, again with schedules in mind. Some risk monitoring also demands direct active monitoring, and contact tracing may be involved. Low risk will either require active monitoring or direct active monitoring. And active monitoring will be performed by the epidemiology field surveillance staff. Direct active monitoring, again, will be performed by local communicable disease staff, most likely immunizations, but possibly TB, STD, epi, or HIV. Excuse me. Active monitoring. Now, active monitoring means that the public health worker will check at least once a day to see if the traveler has a fever or other Ebola symptoms. This check will most likely happen over the phone, but it could be an in-person visit. The person being monitored for Ebola will have to check his or her symptoms twice a day and give that information to our FSS staff, even though they will only be communicating with that person once a day. When that communication takes place, the field surveillance staff, the FSS, will remind the person being monitored that if they do develop a fever or any symptom of Ebola, to call EPI right away so that we can do an evaluation and so that they can receive medical treatment. The epidemiology surveillance staff here at the central office will call that EVD person being monitored for EVD and gather the demographics that we would have received through the CDC through an EPIX transmission. But again, our surveillance staff will contact that EVD monitoree and make sure that we have all the correct demographics and case information. And our staff will enter it into our disease data system, and then we will contact the FSS by email and by phone. The field staff, the field surveillance staff, will call the individual to make sure that they did receive a monitoring care kit. And one of the things in the monitoring care kit that I did not mention previously is a cell phone that is given by the CDC at the airport. We have that number listed in our EpiX transmission that we get, but a lot of times there's a lot of other numbers that are more easily and readily available to that monitoree. So we make sure that the FSS gets the right phone number and inquires also about any travel plans. And this travel plans includes riding on public transportation, but also, very importantly, if they are going to be going out of our state into another state. If they are going to be going to another state, and Shirley will talk about this more later, we have to notify that other state. The FSS will also inquire if they have pets, and if they do, we will notify our public health state veterinarian, Dr. D. Jones, and Dr. D. Jones will call that EVD monitoree and talk to them about keeping their pet under the care of another person during that 21-day period, making plans for that pet to be cared for should that person become symptomatic. The FSS is also going to inquire as to whether or not that person is on fever reducers, medications like ibuprofen, acetaminophen, and Celebrex. And we want to know this because if we are, one of the main symptoms is fever, we need to know if something is suppressing a fever, and we need to pay more attention to other symptoms. That FSS will discuss the symptoms to report to the FSS. And of course, we'll instruct the person to report a temperature over 100.4 and any symptoms. That person also has to take their temperature a second time and record the morning temperature and the afternoon temperature on their log, along with any symptoms. They need to make sure that our FSS has a contact number to call if the elevated temperature or symptoms occur, and then the FSS will arrange a daily call time to help them remember to call and for them to plan on taking their temperature at a certain time no earlier than 30 minutes prior to the call time. Our FSS have access to our Alabama NetSpace system, so they will enter the call information each day into the system. This is a little bit different for those conducting direct active monitoring. And now I'm going to turn it over to Shirley so that you all can see what is in our ALNBS, and Shirley will discuss some of the information to be gathered as well.
Thank you, Kelly. As Kelly stated, when an individual comes to the state of Alabama from one of the affected areas, then we're notified through the epix. So when we get that email in central office, we look at all of that information that's provided to us. Then we go into ALNBS. And into ALNBS, some of the red areas, this is an actual individual that we monitored, so those red areas is confidential information. But we put in all of the information such as the jurisdiction and what their start date is. CDC gives a designated number to them. We also put in who the investigator is going to be, and that's the FSS in the area. We also find out where they have been, which of the affected areas they've been. We also look at the risk. We do not determine that risk. That risk is determined for us, and it is on the information that is sent by our epix. Then the date of the potential exposure, that is the last date that they were exposed, and that is day 0. So that following day is how we count as our day 1 up to our 21 days. We either put them in the category of direct or active monitoring. And as you remember from our previous discussion, direct monitoring is where we will make a home visit, and active monitoring, so far, we've just made the telephone call. We do inquire if they have any travel plans, and that is travel plans outside of the state of Alabama. But it is very important that the FSS or the DIS, whoever is monitoring, also ask them about travel plans, because when I initially call them or someone from central office calls them to obtain some other information, we inquire about any travel within 21 days, but you know that plans could change. If they do travel or have travel plans outside of the state of Alabama within 21 days, then we require information such as where are they traveling to? We need an address, and I try to get an emergency phone number because we have to notify that arriving state of this information. We need to know how long they're going to be gone, their expected leave date, their expected arrival date, and if they're returning back to the state of Alabama within that 21 days. That information is sent back through our EPIX to that incoming state that they're going to arrive at, and we talk back and forth with them so we know where our individuals are at all times. Okay, and then the next slide, we ask them about any pets they have and what their plans are for their pets if they become symptomatic. And again, as Kelly stated, that Dr. D. Jones will also give them a call. We also talk to them about symptoms to report and ask them to please make sure that they have their telephone available on them at all given times, because this is our method of contacting them. We also have emergency numbers. We try to get as many emergency numbers as we can, just in case for some reason they leave their phone at home. As you will note on the screen, then it has like day 1 and it has an AM and a PM. For those active patients that we are monitoring, then we will call at a designated time and find out what their temperature was in the morning. And if you'll note in that care kit that Kelly was talking about, they have day 1 and a time for their AM and their PM temperature. So we get their temperature and if they had any symptoms for that morning and what time they took their temperature that morning. And then for that afternoon, they're supposed to take their temperature 30 minutes before that arranged call. We document their temperature for that afternoon and that it was by phone call if they've had any symptoms. In the central office, we monitor those temperatures to see if there's been any if they had 99 one day and 95.4 the next day, we want to know why. So we're going to inquire as to why there's a fluctuation in those temperatures. And I'm going to hand this off to Cindy, and then Cindy and I are going to communicate back and forth for a little bit during these.
Yes, thank you, Shirley. Good morning, everyone. We want to talk a little bit more about the direct active monitoring. One thing I do want to mention is they'd mentioned that we should only be monitoring people directly if they're high, some, or low risk. The high risk would only come into play is if we had someone in Alabama with Ebola and then their contacts were assessed. So we're not going to get a high risk assessed person from another country, only in the event if we had a Ebola case. And then we would also, so we would be monitoring some risk and then low risk for travelers. And the low risk, again, is for those EVD patients who were wearing, a low-risk traveler was treating an EVD patient while wearing PPE or sitting within 3 feet of a person who had EVD. So there is only a limited number of cases, and we have had one traveler that's been monitored directly, and we'll talk a little bit more about that in a few minutes. And but that has been completed. Their 21 days has been has come and gone. So the other thing we want to talk about is the direct observation must be in person. If you read the protocols online, it does give ways to do it another way, but right now the process is it must be done in person, and if you for some reason have to do it by a different method, then you would have to get permission and justify why it could not be in person. So that's very important. We want to continue to assess the person twice a day. Part of direct active monitoring is still calling once a day, doing direct active monitoring with a phone call, and then you will once a day go see that person face to face. Okay? So when we talk about who is responsible for this, the immunization staff, the area immunization managers, will be the one responsible for coordinating direct active monitoring. We know that in some areas that would be very long drives, and so we have taken that into consideration, and we're continuing to modify the protocol here and there as we find new situations that were not anticipated. So that's why we wanted to make sure everyone knew that the Bureau of Communicable Disease field staff, everyone could be the one who has to go do the direct active monitoring. The immunization person would be the one coordinating that at the local level. And this is a map, and I know it's hard to read, and it wasn't really meant for you to read right now, but this shows all the field staff that are located throughout the state. So we will look at, but the immunization manager will look to see who is actually the closest person to the person that needs direct active monitoring, and to find out what their availability is. So if we have someone, we want to make sure that it is not occupying too much of any person's schedule, and to make it as convenient for everyone as possible. So we are looking at all other HIV, STD, TB, and immunization staff that could potentially be asked to do the direct active monitoring. Okay, so this was a conversation me and Shirley are going to have a little bit. The surveillance branch staff will still, when they receive from EPIX the information, will put that into the ALNBS, or the NEDS-based system, the demographics and the case information, and then immunization will assign a designated employee to conduct the direct active monitoring based on that map that we saw before. And then Shirley and her staff will email the employee that was selected to do the direct active monitoring and the supervisor and all the pertinent information that we had received from the EPIX. And this needs to be done very quickly. This isn't something that should take more than 24 hours. For all of this to be accomplished from the time we receive the EPIX, we need to get this information going, because the next day that person has to be contacted and monitored face to face. So we do know the area immunization managers have access to ALNBS, but if they are not the ones actually doing the direct active monitoring, we want the person in the field to be able to complete the information requested on this monitoring log and to send it in to EPI, and they'll enter it in for them. So we don't want anything to get hung up anywhere. We want everybody to keep the information flowing as quickly as possible.
Hey, Cindy, and
Oh, yeah.
let me add a
Yes.
comment onto that. This mimics the information that's in ALNBS. So when you do your monitoring on a daily basis, please send this information in daily, because we will need to input it into the system. So if there's any questions, a lot of people have access to this and can look and see what's happening. Under the comment section, some information that may want to go in the comment section is if they plan to travel within 21 days outside of the state of Alabama. You'll also notice that there is a place for the initials of the monitor. At the bottom of this form, which you do not see, there's a place for the monitor to sign in case we have any questions. So this is to be either scanned and emailed to surveillance. You can email them directly to me, or you can, the best thing to do is to send them to CD Fax.
Okay.
Thank you, Cindy.
Sure, thank you, Shirley. And this is an example of the information that you would put in that log. So you would put in both, again, a morning and an afternoon visit, well, morning or afternoon call, and the other one would be the visit, the date that you did that, the time, what the method was, what the outcome was, no signs and symptoms and no fever, and the temperature, that reading that occurred when you called and asked them what their temperature was, and then the direct active monitoring face-to-face visit, what was the temperature, and then any comments. So they've decided now they want to go on a vacation to Texas, so we needed to make sure that that was recorded and it's put into ALMBS. And so we would have to coordinate with Texas to make sure that they picked up the monitoring from the day they arrived in Texas until the 21 days has been completed. And then the initial of who's actually doing that monitoring.
Thank you, Cindy. And also there is a travel form that we will request that you complete with the, again, as I stated earlier, with the address and another emergency contact for that receiving state. So once you notify us, don't wait. If you know that they're leaving, don't wait until the afternoon and fax this in. And if they're leaving tomorrow and then just let us see this, please pick up the phone and call and say, hey, they're leaving tomorrow or they're leaving whatever day, because we have to complete this circle and get all of that information. As we would want as the receiving state, we need to give this to the receiving state.
Yes, that is very important, that we keep the information flowing and it's not sitting with one person for very long at all. Okay. All right, so when you actually do the direct active monitoring, you would call the person in advance and ask them, do they have a fever or are they having any symptoms? And here's a list of the symptoms: the stomach pain, diarrhea, vomiting, bleeding, muscle pain, headaches, feeling weak, or taking any fever-reducing medications. So you would call, so actually you're going to call them twice a day. Once to just ask them the questions, do you have a fever and symptoms? And then you'll call them again an hour before you go to see them face-to-face. Okay? So then you would actually go, if they said no to all of these, then you would schedule the face-to-face. It could be in different locations. It could be at their home. It could be at their work. It could be even at the county health department. So we do want to ask that each person work with the traveler or the person being monitored to make sure that they will be compliant and that they would be easy to find and locate and get this information from them. We want to review, is there any travel changes that have occurred since I talked to you yesterday, and note that. And then, of course, if they have any other phone numbers that we need to contact them, you would document the information on the direct active monitoring log, and then you would fax it to the CD fax that's listed on this slide. So all Alabama Department of Public Health employees, specifically from the Bureau of Communicable Disease, will follow direct active monitoring process. If you have a traveler or a person being monitored that you are not able to locate, and you may want to tell them this as gently as possible, that we have to be able to find you, and if you don't pick up the phone or we're unable to locate you, that may cause, we will have to elevate this to the next level. And I don't mean for you to threaten them in any way with that. They just need to know that our process would be within 2 hours. If we could not find them for the face-to-face, within 2 hours, we would have to notify EPI and they'll notify legal that this is a serious matter. So for these 21 days, we really want to do whatever we can to be helpful to the patient and to get the information that we need. So if the person that you're monitoring, traveler or person, if they have a temperature or have any signs or symptoms of Ebola, again, by the call, you would not go to do that face-to-face that day. You would call EPI, and they would notify the state epidemiologist, Dr. Mary McIntyre. Okay, so we do not expect you to go and talk to anyone if they are telling you they have symptoms. Let me see, was there one other thing I wanted to add before we go into contact tracing? Because that contact tracing begins when they have a symptom. We need to know everybody that they've been in contact with since their symptom onset, whether it's temperature or other clinical signs. So we would want to make sure that the person being monitored was assessed. So a EVD consultation form would have to be completed. So if someone is saying they're having symptoms, we would notify EPI, and then EPI has a process to find out what hospital is closest to them and get them to a healthcare provider to be assessed. And the EVD consultation form would need to be completed and faxed in to see if we need to test this person or do they just have something else. They may just have the flu. But we would still have to go through a higher level of processing with this person than we would the general public. The field surveillance staff or the immunization staff would need to collect the list of contacts and send that to EPI. Here's a list of a form that you would use. It's called List of Community Contacts since date of onset. And so you would get all the information you could from the traveler or the person being monitored. And then there's a separate one if they work in a healthcare facility or a laboratory worker or a funeral home. So it would actually be two different contact forms that would need to be completed. So once the a symptom is reported, the contact lists are completed, EPI is then notified, and then EPI notifies Anthony. Right?
Yes.
Okay, and did you want to start with this slide?
Yeah, we'll start with this one.
Okay. Or I'll do it for you. Go ahead.
Once STD is notified by EPI and provided a list of contacts, either on the list of community contacts or list of occupational contacts, which means either a healthcare worker, laboratory worker, or funeral home staff, we will immediately notify the STD program manager within that particular area and provide them that information of location for the contacts for the EVD patient. Once that is done, the program manager will then assign those contacts for immediately contact to gather all their information and to complete the contact tracing form. The contact tracing form comes in 11 sections. Sections 1 and 2 deal with the interviewer and Ebola case information. Sections 3 through 4 covers contact information, including demographics. Section 5 through 6 relates to exposure history and activities for non-healthcare workers only. And Section 7 through 9 covers healthcare worker exposure history. Now, it is very important that these forms are completed accurately and promptly because the contact tracing interview in the forms drives the classification for all contacts. Once the forms are submitted to EPI through the CD fax line, the state epidemiologist, Dr. McIntyre, will then assess each contact by risk exposure as being high, some low, or no identifiable. Based on risk exposure, all contacts will be monitored as active or direct active for 21 days. Now, this is an example of Section 1 of the contact tracing form. Just give you an indication of what it looks like. And this is an example of Section 7, which deals with the healthcare worker exposure history. So like I said, once this information is completed, they are to be submitted through the CD fax line to EPI. As soon as it's done, that way Dr. McIntyre can then determine the classification of all contacts. And once that is done, then our job is complete, and then it goes back over to EPI.
Okay. And so that kind of summarizes what the current protocols are for all of communicable disease staff: active monitoring, direct active monitoring, and contact tracing. The same will hold true with contact tracing for locally. If there are people that are closer to some of the contacts, it may not be STD, it may be somebody else in one of the other divisions. So we want to make sure that everyone knows that the other HIV, TB are backups to immunization and STD staff. Okay, So what we want to do next is we want Pam Barrett to go over TB direct observation therapy to show the similarities to what is already being done for TB patients.
For at least 25 years, ADPH has provided directly observed therapy for all persons with active tuberculosis, and it has really it's really become the most effective way to ensure that all patients complete an adequate regimen by actually watching every dose of medicine be swallowed. Even patients who seem reliable oftentimes will forget to take medications, and it's over an extended period of time. So it's worldwide. DOT is really the gold standard for treating persons with pulmonary tuberculosis. This also allows healthcare workers to monitor for signs and symptoms of toxicity with the medicine, and to ensure that they are actually getting well while taking the TB treatment. DOT helps the healthcare worker solve any problems that may be barriers to treatment, like if they're homeless or have other social problems. The actual face-to-face contact with these TB cases will allow us to better help them to resolve other problems that may end up affecting their treatment. And it helps the TB patients become non-infectious sooner so that they can resume with their day-to-day lives. So a typical TB case is seen daily by TB staff or sometimes in the clinic, usually daily for 2 weeks, and then at least twice weekly thereafter for approximately 6 months. So regularly scheduled visits to persons with infectious diseases by by health department staff is not a new concept, and direct active monitoring for Ebola patients should not really be any different from that.
Thank you, Pam, for sharing what's currently being done for TB patients right now. And we have a special guest with us. We have had one, as I mentioned, one direct active monitored patient, and DeFellis Dumas is the disease intervention specialist in Jefferson County who did that 21-day direct active monitoring. And I wanted him to share with you his experience doing that with a traveler. DeFellis?
Okay. Thank you for inviting me. First, Dr. Khan had received an email notification from Dr. McIntyre stating that on Thursday evening that we was going to have a direct active monitoring. On the 20th, we received it from Jefferson County, and it was assigned to me that we were going to have someone that we need to follow directly. I had a couple of active monitoring, so I knew about the questions and things that needed to be asked for active monitoring. But there was a little bit more different questionnaire that I need to ask because he's a local physician who had came from Sierra Leone and from Partners of Health, so he was at the some risk category. So when I called him for the first time, basically just to introduce myself, let him know that I will be following him for 21 days, and to let him know that he was going to get several phone calls from other people from around the state. I let him know that that Dr. Jones that was going to call him and talk to him about his animals, and it's a lot more information that I told him later on that I will call him back for. But I just wanted to first get the initial phone call to get a rapport with him, to let him know who I was, what I was going to do, and so I called him again about an hour or 30 minutes before going to his house, and I told him some more information, with the information of if he got sick or had the flu or anything like that, who would be the EMS company that would transport him. And I told him the name of that company. Also, we talked about was he married, did he have any kids, because I thought that was really important to me, because this is a local physician who's coming home, and if he had kids and his wife was there, then that lets me know that he wouldn't want to affect his own family. So that kind of give me a little relief, just saying, okay, that he'll be honest with me. So I went out there to meet with him on the first visit, and after the first visit, unfortunately, it was a little later than about 4 o'clock, so his wife and kids were there. So I met him, we took the temperature. When I went out there, I had my gloves and I had a mask on. I met his wife and his kids when they was coming in, because they was like, oh, hey, how you doing? They didn't know who I was. All they saw was the county car in front of the house. And so when I met them, he introduced them to me. And I didn't have to do the 3 feet with him, because he automatically himself, every time I move, he moved back from me, because she had the respect that, okay, I understand. And so after pretty much day 10, you know, I didn't wear a mask after day 10 of agreeing with him, because I felt pretty much comfortable. We made a rapport. I talked with him because I knew it was 21 days for me to meet with this person. So when I called him, we talked about different things, you know, besides, you know, I'm coming to see you. He also kept me informed with things that was going on in other countries with Ebola. And so he educated me for this 21 days of what goes on. He told me some concerns with me doing this monitoring, because one of his concerns was that he was wondering why we didn't Skype like other states. And his other concern was, you know, if, you know, he got sick or whatever, what was going on. Some of the key points that I had to find out from him was he was going to let his dog stay there, and he refused, and he wanted his dogs to be there with him. His statement was his children and his dogs are going to stay in his house with him. So that was, and it's only a recommendation that his dogs will leave if he's asymptomatic. And I had to find out what hospital, if he was to get sick or anything, what hospital did he prefer to go into. And we got all the information to him. We put it in NEDs so everyone else can know what this physician wanted. The second thing that was very important was, you know, during that time, it was snow in Alabama. So when we was closed, I had to talk to him, and the day before the snow, me, my supervisor, Dr. Khan, and our program manager, we sat down to say, okay, we're going to need to Skype him because it was snow. So I'm not going to go out there and drive in the snow. And so we Skyped him for the days that the health department was closed. I never touched the thermometer. He always stayed 3 feet away. And it is a small thermometer. It's very little, and the screen is really little. So what he did was, after he did the temperature, he held it out far enough for me to read it, because he read it, and then I read it. And so the pros of this was, it was great. I didn't get sick, and he didn't get sick, and so that was one of the things that was fun, and I really enjoyed it, because this particular person was very cooperative with me in this. The only travel he wanted to do was see his brother, and that was like really down the street. And so he stayed at home for 21 days, and I went to his house every day and did the monitoring with him. Will I do it again? Yes. So, and I was very pleased and happy that I was selected to do this monitoring.
Thank you so much, Felix. That's a great story. You brought up a lot of things that could be a little bit different in each of these direct active monitoring situations, and we hope that other staff will have the same upbeat attitude and openness to it. It can be safe. There are a few things that you would precautionary need to do. That 3 feet, another option would be they would take their temperature and put the thermometer down and then step away, and then you step towards the thermometer. So there's a couple of variations of that. could occur, and I appreciate you bringing out some of those variations. And so, yes, Skype was approved, but it was approved with justification because of the weather, and it is not approved for day-to-day routine direct active monitoring without. So if that does come up, you will have to get approval for that in advance. Thank you so much.
Thank you, and thanks to all the panel that has participated today. Again, I just want to add my personal thanks to you, fellas, for not only your commitment to this, but also the practicality of bringing this information to us today and being the person who was the leader in doing our first direct active monitoring in the state of Alabama. Now we'll return to the panel to see if there are any questions from the audience that we could answer. Cindy, do you have any questions?
Yes, I do have one email question that says, who in immunization is going to be monitoring EVD? And I think we've answered that somewhat, but if not, let me clarify. The area immunization managers will be the primary coordinating those events. So it could be a disease or intervention specialist or a staff nurse or up. So it has to be a DIS or nurse, and any classification above that could be the one selected to go do the monitoring. So it could be the area immunization manager if they happen to be the one that's the closest, and they are their schedule doesn't conflict or have any other priorities that are deemed more important than this. Does anyone else have any comments to add to that?
I think the only comment I would add to that is, as immunization is leading this effort, that does not mean that in another area, as you mentioned earlier, in a different area, it might be where the immunization staff might not be the closest, and we would then look at the TB staff or the STD staff. Again, continuing to emphasize that we're all in this as a team effort with the field surveillance staff, and that people aren't going to be out there alone, without information, without education, which is what we're doing today, and in the event of an issue or problem, without consultation of those of us that have been involved. I think that DeFellis' experience underlines that while he was out there leading this, he had his supervisor, he had Dr. Kahn, he had access to the state level program people and also the field surveillance, so that no one is going to be out there alone doing this without access, resources, and backup.
That's a great point.
I did want to point out that Alabama is probably fortunate that we're not in the top 20 as far as with the states that actually are receiving monitorees, which means that we're really down as far as the numbers that we receive, which for this happens to be great. I'm just going to say that. That doesn't mean that we don't expect potentially additional direct active monitorees. So that's why we have to be prepared. We're months in and we've only had one. So we're not expecting huge numbers to occur. There are other states like Georgia next to us who've had to deal with 100 people at a time as far as the number of people they're monitoring, not the number of direct actives, but they've had direct actives because of the situation that they're in as far as the airport. So we need to keep that in mind. And we are all here to address that. And even with the ability with having to go in now to do face-to-face, you know, since we're just starting, that's one of the things Dr. Williamson has asked us to do. We do have the ability to make modifications like we did when the snow was coming, recognizing that we also have to keep our people safe. And so we have the ability to make those changes. We've even talked about the use of iPhone and face-to-face if somebody has that capability to be able, if they have an iPhone and we do, to be able to do that face-to-face contact, to be able to do FaceTime. So we're open to all of that, and we're hoping as this goes on, the reality is this probably going to be something that's going to become pretty routine. And we just need to say that. It doesn't appear to be any end right now to what's going on in West Africa about the numbers, even though there have been some positive things with, that we talked about with the numbers, not having anything recent in one of those countries. And like I remind people, Africa is a continent. It's not a country. It's made up of a lot of countries. And we're only looking at 3 of those at this point in time.
And I'd like to also make a comment that one of the best things that I think happened with this whole outbreak for us in the United States is when the decision was made to route everybody to those 5 airports and get control of knowing how many people were coming in at any time, and that all the states would have the information about who was going into their states, so that nobody would sort of just sneak up on someone in an emergency room and say, oh, I've got Ebola. You know, if you were not one of those who had not come, from those areas, we are aware of who all is in state now. I think that calmed a lot of people down in the different, cities around the country. It calmed down the EMS services, and all of that. So now with most of these people, who will be monitored, the health department and our personnel, being involved, because I always are concerned, like, who's going to do this, who's going to do it. But now we fix it up and, have a plan. I think that this plan will work well. The fact that, we don't have a lot of people, we don't have people who are sick, and people will, I think, want to protect their families and will be truthful to you and not want to be hiding, oh, I'm sick, but I'm not going to tell anybody. Well, then they're going to infect their families and everybody else. So I think this is going to be good, and, if anyone on the staff has any questions or concern, we're available, to ask questions and help to allay some of their fears. Thank you all for putting this on.
Thank you, Dr. White. Are there other questions from the audience, or email or call-in questions?
There are no email questions at this time. Are there any call questions? No calls at this time.
Any questions from the studio audience? Well, again, let me just thank everyone on the panel for a most informative and educational discussion. This discussion today will be archived. It will be in our system. And in addition, in looking at this for continuing education, please feel free to complete all the information as you have been directed in order to receive your continuing education credit. Thank you again, everyone, for participating today. Thank you for being involved in the Alabama Public Health Training Network.